Hello, welcome to Learn from the Case. How are you? Today I want to talk about infective endocarditis. So it will be a video on internal medicine, cardiology. Endocarditis is the disorder that affects the endocardium and heart valves, characterized by lesions produced by various etiologies. In this video, I am going to talk only about infective endocarditis. Infective endocarditis, or often called bacterial endocarditis because most cases are due to bacteria, it is one of the most serious infections. It is characterized by colonization or invasion of the heart valves, the mural endocardium, and sometimes other structures, giving rise to the formation of voluminous and friable vegetations. Friable means easily crumpled. These vegetations will contain microorganisms and thrombotic residues. Many times it has been classified as acute and subacute depending on the severity, form of presentation, etc. Acute endocarditis is a stormy, destructive infection of a previously healthy valve. In order to infect such a valve, it has to be a very virulent pathogen. In this acute type of endocarditis, death occurs in 50% of cases, even when they were treated correctly with antibiotics and surgery. On the other hand, subacute type. Subacute endocarditis occurs in a previously altered heart with congenital or acquired malformations, with nosopathogenic microorganisms, infection that can be propitiated because the protection of these valves is not optimal. That is why the clinical presentation is milder. However, it is not always so clear. It cannot always be said clinically that it is acute or subacute. Among the alterations that predispose to infective endocarditis are myxomatous mitral valve or mitral valve prolapse, calcified degenerative valve stenosis, bicuspid aortic valve, calcified or not, prosthetic valves, valve grafts, neutropenia, immunodeficiency, diabetes mellitus, alcohol consumption, intravenous drug use, among others. The microorganisms that are actually responsible are Streptococcus viridans, also called alpha hemolytic streptococcus, in 50 to 60% of cases, coming from the oropharynx, the genitourinary system, and the digestive tract. Staphylococcus aureus, which is more virulent than the previous one, is responsible of 10 to 20% of cases. It can settle in completely healthy valves, mainly responsible for endocarditis in drug addicts who use the intravenous route. HACEK group, Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella, all commensals of the oral cavity. Enterococci, most commonly Enterococcus faecalis, cause between 5 to 20% of cases of infective endocarditis. They usually occur in older men, and the most common source of infection is the genitourinary tract. They can affect both normal valves and previously damaged valves. Staphylococcus epidermidis, it almost exclusively affects prosthetic valves, gram-negative bacilli, rickettsia, Q fever, and fungi, much less common. They tend to produce larger vegetations than those of bacterial origin. Candid endocarditis, for example, usually occurs the right side of the heart, especially in drug addicts who use the intravenous route. They tend to be friable vegetations, meaning they crumble easily. As they frequently rupture and give rise to emboli, that go to the lungs, causing extensive and polymorphous lesions and also hemorrhage or pulmonary infarction. They go also to the central nervous system, causing meningitis, intracerebral abscesses. They go to the liver, causing liver abscesses. They go to the intestinal, causing enteritis, to the eye, causing endophthalmitis. They go to the skin, they enter it through the skin, but they go from the inner side of the skin, causing abscesses there. Also to joints, giving rise to arthritis, also osteomyelitis. In 90% of cases, there is a positive blood culture, but not always. It is ideal for diagnosis, but it is not always obtained. Then, in the other 10% that do not achieve positive blood culture, it is suspected and treated clinically. Antibiotics are chosen empirically, depending on where the intranasor is located, skin, oral cavity, recent surgery, septic focus in the intestinal tract, etc. The Duke criteria is used for diagnosis. Now the modified Duke criteria. In 1909, the Englishman Thomas Hodder described the signs and symptoms of infective endocarditis, but until 1981, von Rhein proposed his criteria to facilitate the diagnosis, classifying it as definitive, probable, possible, and rejected. In 1994, at Duke University in North Carolina, new criteria, Duke criteria, were proposed, with three options: definitive, possible, and rejected endocarditis. In 2000, Lee and collaborators presented modified and more strict criteria, known as modified Duke criteria, where only the way to reach the possible diagnosis were changed. And in 2023, the ESC, European Society of Cardiology, reviewed the criteria again. Diagnosis of infective endocarditis, Duke University criteria modified by ESC in 2023. Major criteria: positive blood cultures, microorganisms compatible with infective endocarditis in two separate blood cultures, evidence of infective endocarditis in emerging tests, echocardiography, transthoracic, transesophageal, cardiac CT, amongst others. Minor criteria: predisposing factors for infective endocarditis, associated heart disease, intravenous drug use, fever more than 38 degrees Celsius or more than 100 Fahrenheit, embolic phenomena, including if detected only by imaging, major systemic or pulmonary embolism, infarcts or abscesses, hematogenous sepsis, osteoarticular complications, infectious aneurysm, foci of intracranial hemorrhage or ischemia, conjunctival hemorrhages, genuine lesions, immunological phenomena, glomerulonephritis, Osler's nodules, rot spots, rheumatoid factor, microbiological evidence, positive blood culture that does not meet a major criterion, or serological evidence of active infection by a microorganism compatible with infective endocarditis. Then the interpretation: infective endocarditis defined by two major criteria, either one major criterion plus three minor criteria, either five minor criteria. Infective endocarditis possible, one major criterion plus 1 to 2 minor criteria, either 3 to 4 minor criteria. The vegetation of infective endocarditis are usually all friable, voluminous, and potentially destructive. The mitral and aortic valves are the most affected. But in addicts who use the intravenous route, the right heart is affected. Sometimes several valves are affected, sometimes with ring abscess. Thus, the most common infective endocarditis is caused by Streptococcus viridans. Viridans streptococci include several species of alpha hemolytics and non-hemolytic streptococci. These are divided into groups: mites sanguinis, mutans, salivarius, anginosus, bovis. Streptococcus viridans endocarditis almost always occurs in individuals with diseased biological valves or prosthetics valves. It comes, as I already said, from the oropharynx, the genitourinary system, or the digestive tract. Oral surgery, invasive procedures on the intestine, such as a sigmoidoscopy or esophagogastroscopy, usually precede endocarditis. The result of the blood culture generally reads Streptococcus mitis, Streptococcus sanguinis, Streptococcus parasanguinus, Streptococcus oralis, Streptococcus gordonii, Streptococcus mutans, Streptococcus salivarius, Streptococcus vestibularis, Streptococcus sinensis, but don't get dizzy. They all are Streptococcus viridans. And there are patient conditions not local on the head that can cause this infection, such as neutropenia, chemotherapy, hemocytoblastic transplants, both in children and adults, also after radical cytotoxic chemotherapy for the treatment of leukemia. I remember seeing such a case. Clinically, it will be possible to demonstrate fever, the most constant sign, may, however, be absent in subacute presentations, especially in the elderly. There might be little or no fever, murmurs in 90% of cases, but this sometimes does not help if the patient already had murmurs. Fatigue, sometimes with weight loss when time allows, flu-like symptoms, also petechiae, subungual hemorrhage, rod spots in the eye, which are due to retinal microemboli, although these last three clinical signs have become rare due to the shorter evolution at the time of diagnosis. And I could talk about some clinical cases that I have seen, but I don't have any clear in my head right now, and since I don't like to leave gaps in the story, I am going to mention this that I found in Italian medical pages that I found interesting. Here, this first case reads, the article described the case of a 7-year-old boy with ventricular septal defect and a 10 weeks history of non-periodic recurrent fever, repeatedly treated with a short course of antimicrobial therapy. All echocardiograms were negative for valvular vegetation, but all cultures were positive for Streptococcus sanguinis. Infective endocarditis was diagnosed using modified criteria and treated with a prolonged course of appropriate parenteral antimicrobial therapy. I leave the link in the description in case you want to read the whole article by yourself. And a second case that talks about a particular case of a 27-year-old man, homeless, and with a deteriorated state of consciousness and alertness, who was found by some passerby in a park and taken to a clinic in Berlin. This man has a positive blood culture at 72 hours with growth of Streptobacillus miniliformis. And the article clarified that the rat bite fever is a systemic bacterial zoonosis, generally transmitted by rats. The disease is underreported, underdiagnosed, and understudied. The pathogen is Streptococcus moniliformis, and in Asia, also Spirillum minus. These pathogens are present in approximately 100% of all domestics and wild rats, but also in many other rodents. Streptobacillus moniliformis is part of the normal oropharyngeal flora. Rats and mice are carriers and vectors. They don't get the disease. And the article clarifies that, contrary to what the name suggests, a rat bite is not prerequisite for the disease. Indirect contact is sufficient with the penetration of germs through non-intact skin. And with this last thing, I say goodbye today. As always, you are welcome to leave me your comments or questions. Thank you for the attention and be very, very well.